Crumpacker has been a cancer physician for more than 20 years.
I've seen 50 to 100 patients die a year, my own patients. So I saw quite a bit of the end stages and watched some of those patients go through what they considered suffering, and maybe that was not what they wanted.
Kitty Rail has turned to Dr. Crumpacker for help in dying. Under the Oregon law, she can assist Kitty with advice and medication.
I'm getting weaker.
Oregon's Death with Dignity law requires patients to have a 6-month terminal diagnosis before a physician can help them die. 2 doctors must confirm the diagnosis.
This back pain, sometimes it's so bad that I really have trouble getting from...
And the patient must be mentally capable to make the decision.
It hurts.
Do you find that most of your patients are more afraid of pain than of dying itself?
Yes. The conversations don't rotate around the actual death itself.
But the getting there.
But the getting there is how we're going to get there.
When I'm looking at myself and going, I can't do this anymore, I can't manage anymore, I can't get from one place to the other any longer. And it's coming.
Kitty first met with Dr. Crumpacker several months ago. Together, they've completed all the paperwork necessary to apply for the medication that will hasten Kitty's death.
It's a matter of you getting on the phone and calling me, letting me know what your thoughts are. If you...
and I need to talk to my daughters and find out whether they want to be here.
Right.
So I need to take those steps.
I can't participate unless I feel that she has thought about this, not just today, not just yesterday, but that is something she's given a lot of thought to, maybe over the years. And at least since she's had the cancer diagnosis.
It's difficult for me to know at this point what the actual moment's going to be.
How can you predict, yeah.
And I guess I need to have in my mind that it's going to be a time that's available for you. Or, I'm a little...
Why don't you, when you've made up your mind that that's what you want to do and sort of have a time frame in mind, give me a call and we'll...
Work it out.
We
okay.
will work it out.
Okay.
Yeah. And obviously, if you call me and then we've got something set up and you decide at the last minute you're not going to do it, you need...
Sure, I understand
You
that.
are fully in
control. I understand that.
When she chooses to end her life, if she does, how will she do it?
She will take a prescription of a barbiturate, and it's about 2 tablespoons of a bitter powder. So my job is to try to make it not so bitter. And we just mix it in water and add a bunch of sugary syrup, something to kind of hide the bitterness. And you can swallow it in less than a minute. People do that and swallow it in less than 30 seconds. And that takes effect and people go to sleep usually within about 5 minutes. And then they're in a coma, then they die.
And the signs are that it's peaceful?
It's very peaceful.
And you will write that prescription when she calls?
Yes.
Will you be there when she dies?
You bet.
You'll mix the medication for her?
Mm-hmm.
Is that consistent with caring for the dying when you're actually helping them to die?
If that's her sense or anyone else's sense of suffering, that's what I want to do, is relieve that suffering. I am hastening an inevitable death of a terminal person who's competent, an adult, an Oregon resident.
Which means it's legal.
And it's legal.
Dr. Crumpacker was not the original cancer specialist to oversee Kitty's treatment. Dr. Kevin Olson was.
Hey, Kevin.
They're colleagues in the same office.
What's going on with Kitty?
But when Kitty looked for a physician to help her die, she didn't go to Dr. Olson. She knew he was opposed.
I don't feel like I can actively participate in an assisted suicide situation. I can't write the prescription. I'm happy to talk to patients about what their issues are around that, but I just didn't feel like I could or should be the one that actually does this.
Help me to understand why that's so.
Well, I think I haven't been trained in that fashion. I don't feel like I'm competent, but I think more importantly, my own moral framework is such that I don't think that I could do it and feel good about doing it and feel that I was actually helping the situation. I mean, it might be somewhat arbitrary on my part, but because certainly I've given extra morphine to a patient who is in pain, knowing that maybe that extra amount of morphine might be something that would hasten their death. But something visceral inside of me just tells me that this is probably not a direction I should go personally, and so I haven't.
Is that a matter of religious conviction to you?
Well, certainly I'm spent 14 years in Catholic school, so I'm well versed in the religious issues, but I don't know that it's because a priest or somebody tells me I need to do this. It just doesn't feel right to me. And
is it your oath? You took an oath to save life, not in life.
I don't know. I don't know how to. The oath really isn't the issue. It's just a matter of, at the end of the day, when things are done and what I feel good about what I've done. And I just didn't think I could feel good about doing that myself.
No, Neurontin. Yeah.
Dr. Olson does oversee Kitty's hospice care, including her pain medication.
One of the issues that comes up a lot when you talk about helping patients die is that patients will worry that when the going gets really tough, maybe the doctors or the family members won't have enough guts to do the right thing and give them the medicine that they need.
The Dilaudid.
For fear of making things go wrong.
And here we have the amitriptyline.
The Oregon law is controversial, but all sides agree it has led to the use of more pain medication for the dying. Oregon has the highest per capita use of morphine for pain control in the country.
I always tell patients that if I'm ever going to err, I'm going to err on the side of giving you too much rather than too little, because that fear of a painful death, of being in pain and not being able to do anything about it, is really an overriding issue with a lot of dying patients.
Have you used any of the Dilaudid since I was
I
here?
took some this morning.
Okay, how about yesterday,
Yeah,
when you were having so much?
They think that I would be able to get some of the pain to go away if I took more of certain ones of these, but they also just knock you out.
You use 4 of them each time, then?
I was using 3.
Okay. Remember, I kind of suggested that you take 4.
Okay. I want to be able to read and be aware, and I don't want to sit and sleep all day long or, just doze off. I don't want to knock myself out. So we're trying to find something that will give me the quality of life I want and won't just totally knock me out, but we haven't gotten there yet.
Otherwise, you have that nagging, lingering feeling of pain all the time.
There have been occasionally times a patient in the hospital, the nurses will say that, he's clearly restless, he's delirious, we're not sure if giving him more morphine might make things worse, he might stop breathing. I've not worried about that. I've said, listen, we need to make that patient comfortable. Sometimes the only thing keeping them going is that painful stimulus, and you relieve the pain and they die shortly thereafter. But I feel in my heart that it wasn't me that took that patient's life. It was their disease process, and all I did is help them be comfortable in the last moments.
Is it a matter of control? You want to remain in control as a doctor?
Actually, I'm happy to give the patient their own pain medicines and let them choose how to use it. But it's not so much that. It's that if my mission is to make them die, that's a little different than to make them comfortable. And that's maybe where Nancy and I differ a little bit. Nancy doesn't see a distinction between that. And
what about that?
I don't see a distinction. I see the hastening death with a prescription by a patient at his or her home as actually a much better situation, because then it really is hopefully all in the patient's control. In Kitty's case, I'll go out there and if we arranged a time, I'll say, Kitty, are you sure now's the time? I'm going to give her plenty of chance to doubt and to change her mind. There's probably a dozen patients I've had conversations with who have gone through all the steps, who we've never gotten to the point of writing a prescription. They wanted to know that they could have that if the time came that they really wanted it.
The last time I talked to her, she said she wasn't sure she would follow through, but she liked the notion that she has the option if she wants.
I called hospice.
The key thing, I think, if patients are going to go this route, is that they need to have a doctor who will take the time to really work through all the issues and to really make sure that all the other avenues have been explored before they go into this realm. And Nancy's exceptional in that regard.
Thanks for coming over.
Okay.